All right, I'll go ahead and start the meeting at 1 o'clock. Looks like we've got myself, Shelley Bissell, it's like Carrie Hoffman's on the line, Jordana Carpenter, Lauren Bond, Michelle Prentice, Mickey Kovac, Sandy Nygaard, Savannah Sandlin, and Vicky C on the phone. I think we need to start with when this work group was formed. I think it was, we're going to explore potential maltreatment training gaps for EMS. Did anyone have any ideas between forming the work group and now?
That was an awful lot of material. Apparently, I need more education on child abuse, because I missed a couple of those questions. I was doing the one from Colorado, the long one. I started that one, and I missed a couple of the questions. I was like, wait a minute. So apparently, I need education.
Yeah, I added to the calendar item some information from Savannah about pediatric education and advocacy kits. Let me click on that link. Savannah, can you guide me to which one you were talking about?
Keep going down to the one. It was the hour-long one. That one right there from Colorado. That was the one I started.
You did a test drive for us?
Yeah. Like I said, apparently I need more education. A lot of things are kind of subtle, and but if you go with the 10s guideline, you kind of, with the 10-4 faces, that kind of helps you. That's a good it's a good start. That one, yeah.
I know we added like an image to our TTTG.
Yeah,
we need a teaching module.
Mm-hmm.
Savannah?
This also works for the not just for EMS. I mean, it also works for the emergency departments too.
Mm-hmm. Okay, so a 10-4 faces PEDS training. We need a training module for that. Does anyone else in the group have any other thoughts or ideas on that?
Hi, this is Lauren Bond. I am the pediatric trauma coordinator at Valleywise and serve on PACES as a member of a trauma facility. I also, in our guideline at the hospital, we also utilize the 10-4 faces. So that's something I agree with. Another thing is that our trauma hospitals are required to have a maltreatment screening of some type, some process established. And I think that's pretty standard. I've worked at Desert and at Valleywise, and it's the same 6 questions that we ask repeatedly. So I think that's another thing just to take a look at for EMS, to be thinking about those types of questions when they're evaluating a patient in their homes or whatever it might be. Those questions are just the typical, like, is injury consistent with their developmental age? Is it consistent with their history? And then it goes into unexplained injuries, or is there delay in the family seeking care? Is there any obvious signs of abuse? And then the bruising is guided by the 10-4 faces algorithm or optic.
And we have a very similar process at Honor Health as well, very much to what Lauren had just commented on.
Okay, so if we generate a slide deck with training to those questions, that would be a good goal for us.
I think it'd be a great goal, because in the pre-hospital environment, and please, people, if I am wrong, please correct me. They don't get a tremendous amount of training and education on recognizing child abuse. So I think this is super important.
Let me get a slide deck.
Boy, we really need Amber for guidance. Where is she?
I'm sure another meeting. Templates.
I think I got it working now. I was gonna say on the pre-hospital side, our education for child abuse is one chapter and it takes about 2 hours to lecture.
And that really, to be honest with you, is not enough.
No, I make sure I get, like, for me personally, I know that the students all get the 10-4 FACES cards. I get from Lisa over at PCH, but it's something that I try to bring up during refreshers and everything else. But you're right, I don't think we get enough, and I don't think it's clear enough in like Image Trend or the software that they use for documentation.
And you're up in the northern country, so not everybody is privy to your education, what you do.
But that's exactly right, because when I did the child abuse lecture for the PEDS symposium, a lot of people hadn't heard of it from up north and down south. We had them from all over. So I don't think that we're getting enough refresher on it.
Yeah. Well, Michelle, when I get your students, we'll quiz them.
Please do. If I need to beat them, let me know.
Okay, I've got a slide deck and I'm sending you all a link for editing rights. Can I kick off adding the questions and what we want to train to? And then I can add an image of the 10-4 FACES P to the slide deck as well.
Yeah. I guess they can kind of put the slide, just drop them in and then sort them all out later. Oh, there's Dr. Woolridge to help us out.
Hi, everybody. Sorry for calling in late.
We were just mentioning that we truly don't think there's enough education for the pre-hospital world on recognizing the signs of malnutrition and child abuse.
Yeah, I agree. I agree.
All right. And from what I remember, we're going to train to the 6 questions on the screening. Does that sound correct? So question 1.
I think it's a good idea just to put out there, because when I'm, triaging as an ER nurse, these are the types of questions that we ask, and I'm thinking about some level of suspicion while triaging patients coming into the ER. So I think those questions in people's mind are just a good idea when they're on scene.
Whoever wants to talk, go ahead.
Vicky has her hand up.
Hi, I'm Vicki Casmont. Sandy invited me to this. I am the trauma PEDS coordinator here at Banner Ironwood. I'm also a TNCC and EMPC instructor. And so one of the things that I think, when we're teaching that part about child maltreatment and stuff to our ED nurses and trauma nurses, is that one of the biggest things is your assessment of, does the story fit with the injury, and really using your spidey senses and knowing that if there's something that doesn't look like, smell like, feel like, that there's no harm in reporting it, because we are mandatory reporters and it's not up to us to make judgments, but it is up to us to do our suspicions and let others investigate. So that's just my 2 cents.
And I think sometimes too that EMS may forget that they too are mandatory support reporters.
Interesting, in that there's a bill that's going through the Arizona legislature that may alter the mandatory reporting laws. In that currently the bill states, or I'm sorry, currently regulation states to report or have a report be made. If the current bill is successful, it would require everybody with concern would do their individual report. So in our current practice, EMS is very, takes advantage of the fact that the hospital eventually makes that mandatory report, and that they don't necessarily have to, prior to the handoff. But if the bill is successful, EMS will also need to, by statute, make their own report.
Copying and pasting out of the chat here. Thank you, Lauren.
No problem.
When you're done with that, I think we ought to definitely in there ought to be something of explaining developmental. I can't talk today. What's wrong with me? The stages of development. There we go.
Between you're not talking and mine not typing, we'll be fine. Oh my God, that's the horrible pressure of typing in the group here. The formatting.
You do a really good job.
Why is it doing that? Anna, did you get your microphone working?
Sorry, Shelley, are you talking to me?
Yeah.
Oh, yes.
We're gonna wait, add a slide. Gonna put the rules first before the rules, meaning mandatory reporting information for this or after this.
If we get everything, if we get the information on the slides, we can always juggle them around later on.
All right, and you're teaching on, is the injury consistent with developmental age? That's a good thing for EMS to keep in mind.
I think the biggest milestones that we see in the hospital are rolling over prior to an infant being able to roll, and then injuries when a child's not ambulatory. So I think we can highlight those for EMS, but there might be more. There might be other ones that are important to add as well. Those are the top two that are coming to my mind.
Should we maybe put scenarios and like maybe some pictures to help with that?
Absolutely, all those types
I
of
like
things,
those
I think, help.
scenarios that were in the Colorado one. Because they were very educational.
Savannah, are you in that, or Jordana, are you in that Colorado training right now to extract an image or a scenario?
No, I don't even know what Colorado training you're talking about. So, but I can look it up.
It was,
Oh,
yeah, it's in the link. I can
Oh.
pull it up.
Yeah, I'll look through it as well right now. They were just it's a training from EMS Colorado on child abuse recognition.
Oh, okay. I missed that part.
Yeah, their module had a series of over 100 photographs asking the person going through the module, would you report, would you not report? That's the one I looked at. And there was a lot of images available there. And I think that's all grant funded, so I don't think it's proprietary at all.
I started answering those questions and decided I needed more education.
Yeah, and the explanations after you clicked on yes or no, I think prompted a good understanding of the rationale behind each image. So I thought it was a pretty good module.
Yep.
okay. So for question 1, is the injury consistent with developmental age? Do we want to say milestones, for example, being ambulatory, or something to consider when determining if a child's injury would be sustained in the way the adult described? Is that appropriate?
I like the example that Lauren had used with like, I think the biggest thing is like rolling over. So we get a lot of kids that come in that are supposedly roll off the couch before they're able to even hit that milestone of rolling. So I think that that is a huge one that we should definitely include.
What is the age of the rolling? I mean, I have 2 adult children. I don't remember.
I believe it's 4 to
Right.
6 months.
Okay.
For rolling, rolling is more like 2 months. They will roll face down to face up first, and that's usually earliest about 6 weeks. I think you can conveniently say 2 months on that, and then they usually roll the other way a little bit later. But I would say 2 months for that.
Okay. Two, is the injury consistent with the kind of verbiage should I type in here?
This would be examples of like if an injury pattern looks like what the patient described. We've had an infant roll off of the bed. However, the injury to their head looks almost like a puncture, like they would have needed to hit something that isn't a flat surface, such as the floor. So things like that. But it also, I believe, is asking too if their histories are changing as well.
You could also put something like burn patterns, a circumferential burn, basically is going to be different than a scatter burn because especially if, they're of walking age, they're not going to stand still and just get that circumferential burn, whereas that looks like somebody held them down. I mean, that burn patterns would be an example as well.
I mean, spelling out the question a little bit clearer. I mean, is the injury scene consistent with the mechanism that was reported to have caused the injury?
Yeah.
But I also like to comment about inconsistency. Is the history changing? That's another red flag that we like to look for. And yeah, there you go. Inconsistent stories like that. With stories with the events that occurred. What do you guys think of the?
What about mechanism of injury?
Yeah.
Like that. See, I need to make it bigger. Is the injury scene consistent with the mechanism of injury reported to have caused the injury? Are you hearing inconsistent stories about the events that occurred or about patients? To determining if the injury pattern looks like what the adult described. The injury pattern looks like what would be consistent. For example, they say a child rolled off but the injury appears to be a puncture. What do we want to say about burn patterns? Again, please, sorry.
Is it a scattered pattern versus a circumferential or patterned? I don't know the word to use, but like scatter, you would expect if somebody got into something hot, it's going to splatter. They're going to be scattered injuries. Whereas if it's a intentional burn, they're going to be held down into water or something, for example, and it's going to be patterned, circumferential, that sort of thing.
And we can always add diagrams or pictures of those two.
I think spattered is actually a really good word for the pattern.
Spattered.
Yeah, spattered, like, or if you want an example, like flicking paint on a wall where you have an uneven line, as opposed to, as you were saying before, that they're held down. It's a nice, cleaner circumferential burn usually.
Uneven lines would indicate the child pulled away. Whereas even lines would for force.
Resistance?
Yeah, I just see it as variable. I mean, it really depends on the mechanism of injury. You know, the hot cup of soup that the child tries to drink is going to have a flow pattern, and that may have clean edges. So talking about flow patterns, you know, the events that occurred, the splattering for splash-related burns, thermal injury, I totally agree. There's just a lot of variation. So I think a comment made earlier about maybe having some images that would give an example, I think would be helpful.
I need somebody to help me roll through the chat too and see what all was added there. Oh, looks like people are adding slides. Thank you, Savannah.
Yeah, I just
Jordana.
I just added the first few examples from the EMSC Colorado training. So I don't know if we are looking to use those images specifically, then I can try to find a contact at EMSC Colorado to just ask for permission, because I'm not sure where they got the images from. Otherwise, we could use them just as a placeholder for what we would want to create.
And I don't really know the rules of publication on these, but Suzanne Buchanan, who's the outreach for the Burn Center at Valleywise, she has a maltreatment presentation, including pictures, that was presented in 2025 at the Maltreatment Symposium at PCH. I don't know if that's an option for us as well. I can ask her.
That would be
Yeah.
great.
Yeah, absolutely. I mean, if she's the owner of those images, for sure. Gaining permission is really, you got to find the owner and very often document written permission.
Gotcha.
If it's grant funded, if it's federally grant funded, those are all public domain, non-proprietary. So a lot of the EMSC work that was done, I think probably including the Colorado stuff we're talking about, if it was grant funded, we should be able to use it. But for diplomacy, of course, let's contact them and get permission. But it should not be proprietary if it was grant funded.
Okay.
I think probably at the end of the presentation, some of the case studies would be nice. You know what Samantha's put in there, Savannah rather has put in there, because they really they really do they do test you, and I think it's good to have some form of a test at the end of the presentation.
Does anyone know if there is a report that comes out about child maltreatment specific to Arizona, where we might be able to find, for example, what the top cases are? Because then we could align images with or scenarios with something like that.
Should be isn't it in the trauma reporting, Shelley? Isn't it in the presentation that the staff does?
I
The
know
intakes for pediatrics.
Dale was chair on the committee.
Yeah. Well, the child fatality review would be a good source, but those are only the deaths.
Oh, okay.
Otherwise, Arizona DCS does have generalized data. I don't think they drill down very well. I think getting into the Bureau's trauma data might be of help. But I don't know of anything that's just central and robust. But DCS should have some information about Arizona statistics.
We want fatality data on here or no?
It would be an incomplete picture. It'd be inclusive of, I would hope it would be inclusive of DCS data. For head injuries, yeah, fatality, I think would be, pretty helpful in that regard, because the head injuries tend to be the kiddos that die. But that's not, that wouldn't be an overall view. I think the DCS would probably be the first place to go.
And I can probably get something from our cares, our Dr. Singleton is our child abuse for Banner. He probably has, yeah, I'm sure they'll have something.
Yeah, Sean should have some stuff.
Okay. Do we want to keep typing here, or should we pause, do some outreach? And then maybe have another work group before the next meeting.
Shelley, not to be nitpicking, but slide 4, I think you had a typo.
Probably.
Question 6, it's just 10 singular, unless I don't, unless the acronym changed. So,
right.
Yeah, there you go.
I wanted to make one more suggestion, just referencing back to the guideline we have about our maltreatment workups. We have a section that's titled Features that are highly suggestive of non-accidental trauma or warranting further evaluation. They break it down into 3 different subcategories. One is soft tissues, which is the 10-4 faces. The next one is burns, and the next one is fractures. So I just wanted to suggest that as a way to organize it. There's a couple points that are not too specific regarding burns. It talks about branding with an object as opposed to a child being developmentally able to grab non-confluent burn areas. And then they talk about fractures in non-ambulatory children. And I think the rest of them might be hard for an EMS provider to make out, because it's really once you've gotten imaging and can see that they have those type of fracture patterns. So just as a thought of a way to organize how we address different types of injuries in this presentation.
Okay. Thank you for that insight.
And I just added 2 more questions that were put in the chat. First by Carrie Hoffman, is the behavior of the patient and interaction with caregivers appropriate? And then from Vicki Kassabaum, is the patient able to walk with or without holding on? I don't know if I just put them there because they were in the chat.
Thank you. Do we want to pause the work groups and do some outreach and reconvene? I think we have a lot of good ideas. Just need to get it all distilled for the EMS perspective.
My only question is before we do that, is there any other sections of the training that we would want to add? Any other topics we'd want to cover? Because we can maybe try to, if we want to add more to this outline, then when we come back together, we can really just finalize everything.
I can comment on that. I think it's really important for EMS to be aware of features in the household that can be suggestive of either a negligent environment or suggestive of neglect. I think the EMS personnel coming in and them identifying and having a concern to transport is key. but them relaying what they saw on the scene, I think is really important. So I
Absolutely.
think, I think a section that would be dedicated towards that would be really helpful.
I also am curious if maybe we should put something in here about mandatory reporting, just as a little highlight overview of, hey, don't forget you are a mandated reporter. Just because you hand off to the hospital doesn't mean it's going to be done. So make sure, you know, just that kind of point.
Yeah, I totally agree with that for sure.
I still think we need to have a section in there, also on the stages of development, because they might not, some of EMS might not recognize the different stages of development.
Very good.
Where would you want that to go, Sandy?
Well, I think it should be fairly early, because then they will kind of know what they're looking for. You know, if we're talking about rolling off the bed, well, how old is that child? I mean, you know, I just think we need something in there about the stages of development that, you know, at 2 months they should be able to. So if they're talking about a 6-week-old baby that rolls off the bed, oh, that's a problem.
Yeah. What a question for the group? What kind of format are you guys envisioning? Because slide number 4 has all of our questions, and is the slide set then going to sequentially go through each one of those? Then I think that would be defined. That would define where, if you wouldn't mind, Shelley, slide 4. That's where we would, you know, when we talk about, oh, it moved. I'm sorry. I guess it's 6 now. Slide 6. Yeah. So, so do you plan on, do we plan on making a slide set that incrementally goes through each of the questions? And I guess I would answer it that way. So, developmental age, that's our first question. So I think those slides and giving some of the gross motor development stages would go in that section.
Yeah.
Unless you guys
I'll make a note.
Shelley, I just sent you a image of child development resource reference guide. If you want to look at that and maybe put that on the next slide, it might help with that.
Okay. Send it to me on email, chat. Oh, there's the chat. So many ways to communicate now. Thank you, Giordano. I'll work on getting a clear copy of this, but so Giordano shared with me.
Yeah, just maybe as a placeholder, we can get our own copy. I just wanted to throw that at you.
That's super helpful. And then we could put like the major things on the bottom of each question slide, what they could be looking for, depending on age. Okay. All right. Savannah, did you want to do some outreach? And maybe we could reschedule another one of these before the next education committee meetings.
Sure. Yeah, I can reach out to EMSC Colorado about the images. And then did someone, it sounded like
Suzanne Buchanan.
Yes, I had mentioned getting a presentation from her maltreatment symposium. So I will ask her and then can send it to Savannah.
I've lectured on this quite a few times, so if you guys need more material, I'm happy to donate too.
Okay. We'll work
And if
on
I
getting-
could, and if I could, Shelley, or to the group, the current slide we're looking at, question 8 is definitely a big component of question 1, but I'm wondering, should question 8 be a standalone, or should that be included when we discuss question 1?
Yeah, I was thinking that myself too. It was very close to, I mean, but that's like a sub of wondering.
Yeah.
It's more like an example because it gives you a clue that if, you know, they're saying that they tripped and fell and they're not a walker, that sort of thing.
Cool.
I'm looking at the ATLS kind of chapter right now on child maltreatment, and they have some very simple ways that they're teaching the trauma surgeons and stuff. And a couple of the questions they ask is there a history of hospital or doctor shopping? And I think EMS might be clued in on that a lot if they're saying, no, we don't want to go to that facility, you know, when you're transporting them because they don't treat us right or something like that. I mean, that would give me kind of a red flag. I mean, I don't know where we would put that as looking for in the questions, but it is kind of one of the things. And then repeated visits, like if they're running on the same patient over and over with different injuries and illnesses, that, you know, they can kind of see that pattern as well. And then when they're talking about on the injury inconsistent with history, it says the history of injury changes or is different between parents or caregivers. So like the very differences. So they kind of have it broken down that way.
I would be cautious as to saying just because they're a quote unquote frequent flyer means that there's abuse.
I'm not saying it's saying it is, but it's a red flag. I mean, because all of it is red flags, right? I mean, we're not calling it abuse right then and there. It's just a red flag that tells you maybe there is something that you're thinking about. I don't know, just throwing that out there.
we could make a note there, just saying like a reminder about children with, you know, medically complex children who may also be frequent flyers.
Mm-hmm.
Could you also maybe possibly include that in the question for any delays in seeking care? So any delays in seeking care or having specific needs for, you know what I mean? You can kind of combine that component to that question of delays in seeking care, or like a history of that, like hospital or doctor shopping. That could kind of be part of that. Because we see that where they have like those kind of go hand in hand a lot of times in some of the cases that we've seen. So that might be a good like transition of, was there delays in seeking care? And then if there was, did they have kind of like particular needs of that? It might be a good flow for that.
Kelly, can I make slides for each of the questions since that's how we're gonna plan to organize it?
Yeah, I think slides for each question at the top, and then a note on what the child development stages are at the bottom. I think another way we could approach this while we're working on the fleshing out each slide is when we get a draft ready, we could circulate it with this group before the next education committee meeting. And then if it feels like we need another work group, we could schedule one at that time. If everybody's fresh for time. That sound okay? Right. We'll keep working on these slides. And Savannah's going to do some outreach, and then we'll share out the draft that we come up with, I think, in a week or two's time. And because the next education committee meeting is March 19th. So we have a couple weeks before then. We'll share it out and see if the group feels the need to come together again, or we can just talk about any other updates needed during the education committee meeting. So do we have consensus for that plan?
Yep, I think that's a good idea.
Yes.
Okay. Great. Well, thank you all for sharing your wealth of knowledge and wonderful resources. And I think we can be done for this work group. And we'll share a draft out in a couple weeks, a week. I'll get with Savannah and we'll see if we can hurry it up.
Shelley,
Thanks,
do
everybody.
you want us to send you any suggestions or anything that we feel we might want to add prior to that?
Yeah, absolutely. Savannah and I can be point on this. Point of contact for that. Great.
I mean, I mean, to some degree, I'm trying not to reinvent the wheel. I have a lecture that I've done on identifying abuse that follows the escape tool, which is the 7 questions pretty much that we have listed. I mean, I can send it to you all if you think we can. You guys are welcome to scalp any of it that you'd like. I know there's other resources that we're pulling together, but I'm happy to share the lecture set that I put together. If that would
Okay.
help. Okay,
Yeah.
I'll send it out to the group.
Thank you, Dale.
Okay.
Thank you, everybody. We'll go ahead and conclude, and we'll keep working on this and get a draft out to you shortly.
Thank you, Shelley.
Thank you.
Thanks, everybody.
everyone.
Thank you.